protein, a little more broad than carotid IMT, but similar to a recommendation. So I think we did very well. And this was before some of the data I'm going to show you in a moment. So just as a background, we already have a 2A recommendation for intermediate risk and for persons with diabetes, and a 2B recommendation for patients who are at low to intermediate risk. And Alan Taylor contributed a lot to this recommendation because of his PAC study with age over 40, or men that were mean age about 40, showing diagnostic accuracy and prognostic importance, rather, of calcium. The most recent guidelines that I'm aware of that specifically address coronary calcium are these European guidelines, and they also give calcium scoring a 2A recommendation in their terminology for modest risk, which probably would correlate pretty well to our intermediate risk. And after each of those guidelines came out, there's been a number of large-scale publications that have further reinforced the role of coronary calcium. This is approximate 7-year follow-up from MESA. Just as a background, MESA, 6,814 patients, followed up now going on just over 10 years. So we will be able to start publishing on 10-year risk, so true 10-year risk, not just extrapolated 10-year risk. So we'll have that in MESA shortly. This showed that the only thing that really moved overall diagnostic accuracy of Framingham in the entire population was coronary calcium, with an improvement in the area under the curve that I think is quite dramatic. It went from about 0.61 to 0.78. So a big improvement in the area under the curve. And this was published in JAMA, and I think has received very widespread acceptance as another validation in the coronary calcium arena. That was followed within the same month by this paper from the Rotterdam Heart Study. Also, I think a very robust paper. This is another population-based study, a little bit older aged persons, and you can see here that the best predictor by far was CAC score with a hazard ratio of 6.2 after multivariate analysis. You can see some things didn't work at all. PAD, pulse wave velocity, didn't predict robustly. NT-proBNP was the next one, which is kind of interesting because we always thought of that as a heart failure marker, but may actually have something to do with myocardial stretch and maybe a good predictor of coronary artery disease. And then simple things like leukocyte count beat out C-reactive protein. And then carotid IMT was also independently predictive, and I'll let Tasneem discuss that. Another approach that we've taken in terms of coronary calcium has been this looking at using calcium scoring to affect the number needed to treat. So this is an analysis from MESA based on cardiovascular risk and then aspirin use. And you can see here they looked at real 5-year heart event rates to make these calculations. And if you had a calcium score of 0, because the 5-year event rate is so low, you would need to treat almost 1,400 persons with an aspirin tablet to affect one benefit. If the calcium score is greater than 100, because the event rate is so high, the number needed to treat goes down to 28 persons. So we have similar data like this with statins in MESA, and we are now working on a paper looking at a polypill model to show the number needed to treat goes down and down and down.
Circle the fourth line, is that a full screen?
So I think one of the biggest benefits here in this kind of modeling is that we could potentially use coronary calcium as an entree into who to treat for randomized trials. You can imagine the power would go down dramatically, or the sample size would go down dramatically if we documented atherosclerosis before we put patients on medicines that may potentially improve atherosclerotic imaging. So this helps us both clinically and from a research environment. And we're now trying to approach several companies to do studies where they use TAC as an entry into their trial of primary, especially for primary prevention trials, to identify those who at least have some atherosclerosis before randomizing them to an anti-atherosclerotic medication. This is an interesting paper that came out in JACC. This is on calcium scoring and congestive heart failure. So this was about 2,000 papers, also from the Rotterdam Heart Study, showing that if your calcium score was less than 10, your risk of developing heart failure was very low, and it went up increasingly with increasing calcium scores. Obviously, this must be driven mostly by an ischemic cardiomyopathy and hasn't been as well reproduced in the RECALL study or in MESA, but I think the reason may be that Rotterdam was an older population, so the chance of developing heart failure would have been more driven by ischemic cardiomyopathy than perhaps dilated cardiomyopathy. I published in 1995 that dilated cardiomyopathies tend to have scores of 0, so that we would be a poor predictor of dilated cardiomyopathy. And I don't know if Jay, I think Jay is on the line, and maybe he can talk during the discussion about his model and how it outperformed calcium scoring in MESA. And again, I think that's for heart failure, and I think that's important to recognize that we could probably only obviously diagnose ischemic cardiomyopathy. But it did have a hazard ratio of 4.1. It was highly predictive, and the net reclassification was 34%, which I think is a very dramatic number for a concept of simple looking for heart failure free survival.
Yeah, but is this adjusted for age, Matt?
Yeah, I don't know if I can go back. I apologize. Let me see. This is multivariate adjustment. Yeah, so the net reclassification and the hazard ratio are multivariate adjustment. Rotterdam is actually probably one of the most diligent at doing multivariate analyses. So this is all adjusted for age and gender, cardiac risk factors. The one thing about Rotterdam Heart, I think their entry criteria, their entry age was about 71. So you can imagine if you're in your 70s already and you develop new onset CHF, it's almost definitely going to be an ischemic cardiomyopathy, or the likelihood would be much higher.
It's ischemic disease, right?
Right.
Muted. Unmuted.
Some of the younger cohort studies like MESA. Another big area of interest and some nice studies have come out of some of the lung cancer screening studies, where they're now looking at coronary calcium using what Shemesh and others have called an ordinal scoring system. They give a score of 0 to 3 per major vessel. So if they deem it just semi-quantitatively, if they say, oh, that's severe calcium in the LAD, that's 3 points. If they say there's moderate calcium in the right, that adds another 2 points. So the scoring can go from 0, no calcium detected, to from 0, no calcium detected, all the way up to a 12 if they had severe calcification of the left main LAD, circ, and right. So they had a 1.2% cardiovascular death over 6 years. These were high-risk patients because they were smokers. They were older patients, so they were generally high-risk asymptomatic patients. To get into the trials, they had to be prior or active smokers, and they had to be older, so they had at least some cardiovascular risk. Their risk, if they had no detectable calcium score on an ungated lung scan, was 1.2%. And that went up proportionally for each increment of ordinal score. So a score of 1 to 3 increased the risk of dying by 50%. A score of 4 to 6 quadrupled the risk. And a score of 7 to 12 increased the risk a little bit further. Overall, they said there was a 4.7-fold increased predictor of cardiovascular death. And these were adjudicated cardiovascular deaths Obviously, lung cancer deaths were excluded from this. But I think at least promising that for those people who don't have gated studies, we could start tapping into the 30 million lung scans done every year in the U.S. and getting some measure of atherosclerosis. Mike Cricky and I have a grant into the NIH that I mentioned earlier, scored in the 9th percentile. We're still waiting to see if they're going to fund it or not. That's going to compare the ordinal scoring system to the Agatston scoring system in MESA. So we'll see how well this performs, and with some looking at some density factors as well to see if density plays a role in prediction of calcium density. So we'll see what happens there. I'm not going to touch on progression now because Harvey is going to, or I'm going to do that for Harvey. So I'll conclude with, again, the simple concept that we can move up to the eyes of mediocrity for the ancient Chinese if we just look for subclinical atherosclerosis, and maybe someday we'll be smart enough to prevent atherosclerosis. I think we'll have to depend on PK's vaccine for that. So we're not quite there yet, but we'll see. So that's all I wanted to touch on, and maybe we can have time to open it up for discussion.
Also, thank you, Matt. I'm also wondering whether your second talk may not just be better to have you follow it up now.
I can do that if you'd like. Sure.
What do you think,
Matt,
Mark?
it would be good. Yeah, it would be good if you could bring your slides, and while you're bringing your slides, I think it would be good, before we forget some of these points that you brought up, have a little discussions, PK, if you don't mind.
Yes, absolutely. Let's have the discussion now, and then we can follow it up with the second talk.
Yeah, the second talk for progression. So the
Right.
first talk is the accuracy and reliability of coronary calcium for risk assessment. Apparently 2 or 3 new trials that Matt just shared just put more, I think, cement under the SHAPE foundation. So Matt, as far as heart failure, this is new to me. Is there something that SHAPE should pay attention to? Obviously, it's ischemic cardiomyopathy we're talking about. Is there anything that we need to pay attention to or add to our descriptions and guidelines?
Well, I mean, I think it's just another added benefit. Obviously, if somebody has a lot of coronary calcium, their risk of getting heart failure as an independent endpoint clearly is there. And if you look at ischemic cardiomyopathy, if we adjudicate MESA for ischemic cardiomyopathy, you know, see calcium scoring is very good for that. So, you know, we could just kind of mention it in a subsequent version of SHAPE that it also has some predictive power to predict ischemic cardiomyopathy, and that might just be an added benefit of CAC scanning. I don't think we want to start advocating, you know, calcium scoring should be used predominantly to identify who's going to go into heart failure, but I think it is an added benefit.
I think
can you comment on number need to treatment for aspirin versus multiple therapies that Matt showed?
I mean, I think we have pretty good data. I didn't show the old St. Francis Heart study, but in St. Francis Heart, a calcium score above the 80th percentile, number needed to treat was 30 for absolute risk reduction, which was 3.3%. That's atorvastatin 20 milligrams. If you take a calcium score greater than 400, the number needed to treat drops to 16 in that trial. So literally, that's real numbers, not projected. So you treated 16 patients with a calcium score above 400 with atorvastatin 20 milligrams, and you prevented a major cardiovascular event. Keep in mind that in St. Francis, both sides were given aspirin. So that's after aspirin therapy, even in the control group. So it's pretty robust data that we get down to an NNT of 16 for statin use, and we get down to an NNT of about 27 for aspirin use. And now we're going to have some polypill, Karam Nasir is working on a paper with somebody named Bittencourt, Marcio Bittencourt, on a polypill model for MESA to show that the number needed to treat is very low, maybe 10 people for multiple therapies. So it's going to be pretty dramatic, I think, when we have all this data, and it's just a new way of thinking about how we could use calcium scoring to improve our drug delivery or therapy deliveries.
Matt, I was really intrigued by the data you showed from Rotterdam, where the second most powerful T-proBNP.
Yeah, no, I think that's, we're going to look at that in MESA as well. We have some data. See here, the hazard ratio for NT-proBNP was 2.5, which after
Better than
multivariate analysis
CR.
is very powerful.
Well, NT-proBNP always comes out as a marker for high risk of all cardiovascular morbid events. So
Right.
it's obviously telling us more than just left ventricular failure.
Right.
But do we have any data on aspirin superimposed on a statin? All the aspirin data are pre-statin, aren't they?
Jay, I recall seeing some data, and I don't remember the source, where once you were on a statin, there was very little incremental benefit from aspirin.
Well, that's been my feeling about it. So I don't know if you can use the number needed to treat data as if that's the benefit of aspirin superimposed on a statin.
But I think the powerful information here is that if you have a calcium of 0, you probably don't need calcium. You don't need aspirin, and that is an opportunity to suggesting that there's more benefit in getting calcium.
Right, and we have similar data with statins that there's no long-term benefit. I mean, there's number needed to treat is in the high hundreds for CAC of 0. So it works the same for statins. Because your risk is low, right? You can't make a low. It's hard to make a low-risk person lower risk.
Yeah.
That's a simple algorithm.
Any
Okay.
other? Yeah, go ahead.
Any other questions or comments?
Yeah, I was just going to go around the room, ask everybody. I see so that was, I heard Jay. Sergio, any comment, question?
The other one was Dan.
Very impressive. I was not aware of some of this data, but it's really a powerful argument.
Great. I see Jim Early. Do you have any question?
No, I don't. I do find this NT-proBNP very interesting. We've been promoting that as a biomarker for not only heart failure, but it has emerged in the past as predictive of cardiovascular disease. So this may be confirmatory and a little stronger than we thought.
Actually, one of the comments over there on the CardioScore program or product that came out of Dr. Fuster's HRP study. Matt, you were involved with it. Does that one include BMP or proBNP in that 9 biomarkers?
So the original BG Medicine HRP analysis does not have NT-proBNP, but they now have a revised, better predictor model, and it does include now NT-proBNP. So they added it to their new, what used to be called R7 is now R8, and it includes NT-proBNP.
I see.
So last week, we got approval to do this in MESA there to test the biomarkers from the HRP. So we're going to be taking all of those biomarkers that they studied in HRP and applying and doing the same analyses in MESA. So we'll have another confirmatory study of how well that biomarker panel predicts future events.
Great. I think this was the topic was under Erling Falk. He couldn't make it, and Dr. Fuster was not available. So Matt, anything you know about the CardioScore or AVIR before we end the session? We wanted to touch on these two. CardioScore, as you said, has 9 biomarkers combined in one test, and they got FDA approval. And then AVIR is also is another combo biomarker. So we can touch on that as part of our agenda. Going around the room, PKC, make sure if anybody is. Dan, do you have any comment, Dan Berman?
I made the comment about the aspirin. I guess I would just comment I don't know. I don't think Matt was suggesting that we would reserve statin use for only the patients who have a score of over 400. I think that's a controversial one, but the aspirin one I think would not be controversial at all.
Oh, no, Dan, I totally agree. I just meant to say aspirin, a calcium score of 0, the number needed to treat for statins is dramatically high, and that might be a place to focus SHAPE or to reinforce the SHAPE algorithm that if you have a score of 0, statin use may not be as efficacious or cost-effective.
Yes, yeah, great.
The same thing for aspirin. If you're 0, don't take aspirin.
I think so, and I think there's a lot of studies, including diabetes studies, where they never looked for atherosclerosis, but clearly they must have included a lot of people who had no significant plaque, and therefore the aspirin benefit was muted in a lot of these primary prevention trials.
I think primary prevention on aspirin is very shaky, largely because you are mixing those at risk with those not at risk, and those not at risk is a bigger group.
Right, so I think calcium may help sort that out if we could ever get another trial going with aspirin therapy.
Okay, so I think if there are no further questions, we should have Matt continue with the talk that Harvey would have given, which is the role of repeat coronary calcium scanning.
Yes, thank you. And on behalf of Harvey, here's our data. So first, I think everybody's familiar with the lack of benefit of changing calcium progression under the influence of statins. So calcium scoring as a marker of statin efficacy doesn't seem to work well, and probably because statins cause microcalcification. Maybe one of their processes of stabilizing plaque is actually to cause a little bit of soft plaque to convert to calcified plaque. We're learning from CT angiography that statins have a profound effect on soft plaque, but no significant effect on calcified plaque. So I don't think calcium, we're going to not talk about calcium progression in terms of efficacy of an individual therapy, but rather as a predictor of future cardiovascular events. In those patients who are being treated, this is Paolo Raggi's work, those people being treated, all of these patients in this trial were treated with a statin. They then didn't look at whether they were being treated with a statin. The LDLs were actually exactly the same between the green group and the red group. What was different was how much the calcium score progressed. And in those that were progressors, greater than 15%, you can see a remarkably significant cumulative MI rate. And they had almost 1/3 of the patients over the next 6 years suffered a myocardial infarction, compared to 5% of the patients where the calcium score was stabilized, where there was either no progression at all or minimal progression, less than 15%. Paolo, when he published this, I think the relative risk or the hazard ratio was about 8-to-1 for being a progressor versus a non-progressor. So
this was a progression measured how?
Serial,
so
there was a calcium score at baseline, there was a calcium score at year 1, and then they were followed for the next 6 years.
So it's a 1-year change.
1-year change, yeah.
Right.
All of them were on statins, and the LDL was 110.
Matt, the baseline calcium was 100 and above?
Baseline calcium was 30, greater than 30 to be in the trial.
30.
30, yeah. Paolo mostly used 30 as a cut point for most of his trials, as a minimal calcification that you needed to be in the study.
Now, in this study, do you know the majority were in what range? I know more than 30, but the average
I think it was about 250. I think the mean was about 250 in this population.
Okay.
It was like between 100 and 200 were a lot of the patients.
Okay.
And Matt, when you're referring to percent change, is this per year, or an average over the year, or?
So it's just it was annualized, but the scan follow-up was 1 year later. So this was really a 1-year follow-up scan and then subsequent risk. So it's really an annual change of 15%.
Thank you.
So then Paolo broke it down by, which I thought was very interesting, by baseline score. And you can see on the left, same study, that no patient, no matter what their baseline calcium score was, had significant events if they were non-progressors. So if their calcium score was greater than 1,000 and they were a non-progressor, they had the same rate as a person who had a calcium score of 30 if they were a non-progressor. So it kind of shows you that it's the activity, it's the ongoing change that's more important than the lifetime accumulation of calcification in the coronaries. If you look on the right, you will see that the higher the score, the more dramatic the event rate was. And for those patients with a score above 1,000, 50% of them, half of them, had a myocardial infarction within 2.5 years if they were progressors. And half of them had a myocardial infarction within 6 years if their baseline score was over 100. So if you're a progressor, your event rate is much higher than if you're a non-progressor, irregardless of the baseline score. But the baseline score does modify the overall risk, as you can see on the right. So I looked at my cohort from my original paper of 25,000 patients where we looked at all-cause mortality. And again, we just divvied up based on the same 15% cut point that Paolo used, whether a patient was a non-progressor or a progressor. And you can see here that you're about 3 times more likely to die. This was all-cause mortality if you're a progressor than a non-progressor. And you can see that the survival is much different between those two groups. So we're now following this cohort up. We just did another follow-up run on the Social Security Death Index. So we should be able to present mean follow-up of about 10 years soon in this cohort. MESA then started looking at progression. If you remember, MESA was a progression of atherosclerosis was actually one of their primary aims of the overall trial. And they built in 4 follow-up scans into all of the participants. So patients had a scan about every 2.5 years for 10 years. So we have a lot of calcium scores and a lot of carotid IMTs in MESA. This was a sub-study done by Nathan Wong, who looked at patients with either metabolic syndrome or diabetes and looking at progression. And he just showed that if you had either metabolic syndrome or diabetes, your risk of being a progressor was greater. And if you had them both, you had a much greater risk of events being a progressor. So in the bottom, you can see in blue are the event rates for neither metabolic syndrome or diabetes. The middle group was metabolic syndrome, and the final group was diabetes and metabolic syndrome. And the heart attack rate, the coronary event rate, was the greatest in those patients who had the highest progression rates. They just broke the progressions into tertiles. So the highest progressors had the most events. Intermediate progressors had less. The least progressors had less, and non-progressors, of course, had the lowest event rate. So very nicely laid out, linear. It worked in all 3 groups. That if you're a progressor, you're more likely to have a cardiovascular event. We then this was followed up. This was followed up with a study that looked at calcium progression, again in diabetics, looking at event-free survival, again based on the calcium progression rates. And you can see that if you're a progressor, your event rates are significant across non-diabetes at the top right. You go from 100% survival if you're non-progressing, and with each increase of annual progression, your risk of dying or having a cardiovascular event goes up. That's magnified by persons with diabetes, where the event rate starts out excellent for non-progressors and gets down to 80% survival if you have significant progression, in this study defined by greater than 30% per year increase. this is my data from MESA. It's a different study.
It's not.
I apologize. I didn't realize. I thought the bottom box would have the statin effect, but it doesn't. But you can see the hazard ratios at least go from about 2-fold increased risk, which was highly statistically significant, all the way up to a 7-fold increased risk with patients with diabetes. That was followed up with the most recent data. That's something that was published last month. We published the long-term follow-up in almost 6,000 patients of serial calcium scans. And the bottom slide, I apologize, it's a little bit small. I'm just going to bounce back to the other slide deck real quickly because I have a better slide of this. And I apologize, I wasn't, 1 second here, won't take it right here. Let me show you this one instead. This is the same data, but I think this is the same data, but now readable. So look at the, again, 6,000 patients in MESA. You can look at the non-progressors, that purple color at the very bottom, or those with a trivial progression, less than a change of score of 100, or low progression. And in those 85% of patients, 83% of patients, there was very low event rates in MESA. In the remaining 17% of patients, event rates were significant, were very high. And you can see that if you're progressing by a calcium score of 100 to 200 points, this is absolute now, points per year, your event rate is quite high over 7 years, approaching 20% events just in 7-year time. If you're progressing greater than 200 points, your event rate goes up to almost 30%, and your event rate exceeds 35% if you're rapidly progressing greater than 300 points per year. So again, this ties in the concept that no or minimal calcification progression is associated with a low event rate. And this was irregardless or multivariate analysis including baseline score. And the increase was significant over this period of time. So this is 7-year follow-up after the second scan. This is actually represents 10-year follow-up of the overall cohort. Let's just run back to Harvey's last slide here. So this is the same slide, just not in as much. And then you can see the overall hazard ratio in the study was about a 4-fold increased risk. There was a 4 to 6-fold increased risk if you're a progressor that's compared to a non-progressor in this study. So coronary calcium progression, I think simply stated, if you're a progressor, usually defined as a greater than 15% per year rate, indicates a worse prognosis irrespective of baseline calcium score. Absence of progression indicates excellent prognosis, again irrespective of baseline score. And increased progression, at least in Harvey's estimation, indicates a failure of a statin to be working to halt plaque formation. So you can argue this might be the way to assess the non-responders, if you will, to statin therapy.
Matt,
and that's
can
it.
you comment on the definition of the 15%, how we view it in light of the absolute value? If my absolute value is 10 or 20 or 30, the 15% is much less versus is 200 and 300. Can you comment on that?
Yeah, so, in MESA we tried every model to try to figure out what was the best progression tool. And they all work fairly well. So while you're right, I mean, a 15% from a score of 30 is, 5 points. And 15% on a score of 1,000 is 150 points. It still worked well to predict events. We could look at absolute changes. That's how MESA, that's how that one slide was presented. Clearly that stratifies risk very well as also. And then there's the square root method. John Hokinson from Denver came up with a method of looking at the square root of the change of scores, and that actually predicted events best in my cohort that I presented earlier in 4,000 patients. His method was the most robust predictor. So I think from a simplicity standpoint, I would push the 15% number. I think it's just an easy number to calculate. But we could say, progression greater than 100 points is also a significant progressor. That's really the major cut point in MESA where the curves start to separate. So we could go either way, I think, in shape. But I think this does start to strongly support an algorithm of repeat scanning at some interval.
Okay. Any other questions?
I do have a question, or maybe a couple if we have time, but let me start with one and see if we have time for two. Okay? So I hear you when you say that in the presence of statin therapy, we might expect a paradoxical increase in maybe in a small range of the coronary calcium score. But when we get above a certain range, it's even in the presence of statin, we expect worse predictivity and worse outcomes. But do we have any knowledge on for a certain degree of significant change over time? Let's say more than 30, more than 50, more than 100, whatever you want to consider as an impressive progression rate at annual intervals. Do we know that the presence of the statin or the absence of therapy make a difference in predictivity?
Yeah, that's a great question. So we think, and it's hard to, we don't have randomized trials here really. The only randomized study that we have with statins versus no statin is the St. Francis Heart Study. And in the St. Francis Heart Study, progressors did worse regardless of statin or no statin. But I think you're right. We probably need to look at the absolute changes under the influence of statin therapy versus the influence of non and see if there's a difference between the two. We can certainly do that in MESA. We have excellent data on statin therapy. The only confounder would be we'd have to exclude those patients who converted from no statin to statin in that 2-year interval between the first 2 scans. But I think that's worthwhile doing. And I don't think we really have that data yet available.
Okay.
This is Dan Berman. I have a question for Matt. Some of the studies were based on this 1-year repeat measurement, and some of the studies evaluated multiple times of repeat measurement. I would think that different patients might be identified as progressors or non-progressors depending on the timing of that repeat measurement. And it would seem to me that if we were to come to an agreement about any kind of recommendation on progression, we have to figure out what is the appropriate time interval.
Yes, I totally agree. And I think that to be conservative, we could probably look at either a 2 or 2.5 year interval. And the reason I would come up with those numbers is St. Francis came up with 2 years. They scanned people at 2 years and then showed that progression was a big cardiovascular risk after 2 years. And MESA was about 2.3 or 2.5 years average follow-up between scans. And that's also the largest cohort that we have available.
Matt, this is Ioannis. Do you see any difference between males and females in terms of progression?
Yeah, so males and females and different ethnicities in MESA really didn't matter. They were still independent predictors when you broke it down by subgroup. So we haven't looked at diabetics specifically. Again, in MESA we have that one subgroup, but that's probably a group that progresses a little more rapidly in general. And that had some different numbers from that paper from Malik, but we didn't see much differences between men and women. Just women start out with less calcium overall, so their numbers of people who had positive scores were lower.
Any other questions, thoughts before we move to David Spence, who's going to cover the carotid, entire gamut of carotid IMT, and plaque? Okay, David, I think this scene is yours now. We've moved the presenter to your screen. If you could please press on show my screen. And
I'm going to talk about both the topics, and here's the bottom line, this slide. And I would say, Matt mentioned the radiation people, and I would suggest that radiation is not necessary. Coronary calcium is not necessary. What is radiation-free and just as good as coronary calcium is measurement of carotid plaque burden, which is a different thing from IMT. And measurement of carotid plaque burden is substantially superior to IMT, and Matt just told us that IMT did not add to the area under the curve, whereas coronary calcium did. Here's a nice example of two subjects in a genetic study who had measurement of IMT, plaque area, and plaque volume. This subject here with the IMT that was slightly smaller had twice the plaque area and 10 times the plaque volume of the subject with a slightly higher IMT. And there were two big meta-analyses published in 2012 that showed, first of all, that IMT is a weak predictor of events. The increase in the area under the curve for prediction of events was only something like 3% with IMT. And IMT progression did not predict events. There are several studies showing that carotid plaque is more closely related to coronary artery disease than IMT is. And there are several studies now, including this meta-analysis by NAVA, showing that plaque burden is a stronger predictor of risk than IMT. And the reason is that IMT is not atherosclerosis. IMT is a different phenotype. We started measuring carotid plaque, total plaque area in 1990 and showed in 2002 that after adjusting for all these risk factors, patients in the top quartile of plaque area had 3.4 times higher risk of stroke, death, or MI in 5 years than those in the lowest quartile. And this is really a nice step function, 5, 10, 15, 20% 5-year risk of stroke, death, or MI in patients in the top quartile of plaque area. Plaque area significantly adds to the area under the curve of prediction by risk factors, similar to the Framingham score. And the first large population-based study to compare IMT and plaque area was the Tromsø study. 6,000 volunteers enrolled in the study and followed now up to 10 years, the latest data. And in this study, coronary events were not predicted by IMT in the common carotid. They had to look at IMT in the bulb, which included plaque, to predict coronary events. Here's the prediction of coronary events by plaque area. And the 10-year follow-up study that was published in Stroke 2011 showed that the 10-year stroke risk was more strongly predicted by plaque area than by IMT. IMT was not a significant predictor of stroke in that study. We showed in 2002 that plaque progression, which occurred in half the patients, was a significant predictor of events, that the patients with progression had twice the risk of events after adjusting for everything. So, and I've talked at one of the SHAPE meetings about this use of plaque measurement for treatment of atherosclerosis. 3D ultrasound is what's coming, and we can measure not only plaque volume but vessel wall volume. And this study by Sillison and Fuster used the Philips IU-22 device to measure what they called carotid plaque burden. Because they moved the probe along the artery, they couldn't exactly measure plaque volume. And what's important to understand in this study was that carotid plaque burden was much, much more closely related to coronary calcium than IMT or CRP or any of the other things they mentioned. Carotid plaque burden is a reasonable surrogate for coronary calcium. Carotid plaque burden is also much more sensitive to the effects of therapy than IMT. So here's our study in Stroke 2005 looking at effect of atorvastatin on progression of 3D plaque volume. In 3 months, carotid plaque volume progressed by 16 millimeters cubed on placebo and regressed by 90 millimeters cubed on atorvastatin. The sample sizes needed to show effects of therapy are 2 orders of magnitude smaller than the sample sizes required for IMT studies. If you have a therapy that's only 10% as good as the effect of atorvastatin versus placebo, you only need 51 patients followed 6 months to show the effective therapy. And people say, well, wait a minute, not everybody has plaque. Well, that's pretty much bunk. Here are the data from our stroke prevention clinic showing that the proportion of patients with measurable plaque goes up from 75% at age 35 to 45 to 100% at age 75. Here's how carotid plaque area progresses with age. It progresses linearly with age after age 35 or so. And you say, well, okay, fine. What about patients who don't have any plaque? And then you can measure carotid vessel wall volume, which is essentially 3D IMT. And we showed in the same database from the atorvastatin study that vessel wall volume regressed significantly with atorvastatin and progressed significantly on placebo. Here's our dietary study in Circulation 2010, where regression of carotid vessel wall volume was basically proportional to reduction of blood pressure with weight loss. Here are new data that are in press in stroke, showing in a small sample of people who were selected because they had substantial plaque at baseline, that progression of total plaque volume significantly predicted stroke, death, or myocardial infarction. It also significantly predicted stroke, death, or TIA, any cardiovascular event. Look what happened with IMT progression. Patients with progression of IMT had the lowest risk, and there was a higher risk among the ones with regression or stable IMT. So the problem here is that you cannot measure within individuals in a clinically meaningful time frame progression of IMT. And the reason is that the resolution of carotid ultrasound is about 0.3 millimeters. The annual change is half that. So you cannot measure within individuals the change in IMT within a year, whereas it's very easy to measure change in plaque area or vessel wall volume or plaque volume. So plaque measurement, plaque burden is superior to IMT in a number of ways. It has a much greater dynamic range, about 100-fold greater. It's more predictive of stroke and myocardial infarction. It's more sensitive to the effects of therapy, and it can be used in management of patients. So I suggest that it's time for SHAPE to stop emphasizing IMT and all the guidelines that are published and get on to talking about quantification of carotid plaque burden. How do I get out of this?
Yeah, thanks, Dave. No, just stay right there so we can ask a few questions. So obviously, there's need for sufficient evidence, and so since your first pioneering work on this one until now, as you can see, coronary calcium has been just bombarded with so much data. What is the most, I guess, weight-bearing data that we can rely on to incorporate this into SHAPE guidelines? Second question is the product or the tool or test ready, available for people to use? If it's not ready, it's just in Dr. Fuster's lab, this would not be very relevant. So these two questions, if you can comment, please.
I have
yeah, so
to follow.
Anybody who can measure IMT can measure total plaque area. It's very easy and it's very reliable. The 3D measurements are coming soon, but total plaque area, this is the 3D measurements with the Philips system, and there are several other commercial systems available. But anybody who can measure IMT can measure carotid total plaque area. And here's the Tromsø study. 6,000 people followed 10 years. It was the first study to directly compare IMT and plaque area. And plaque area was much better.
Well, yeah, go ahead, PK. I want to just say
Yeah,
here.
can I ask a question? First of all, I want to acknowledge your fantastic work in this field, and I've been a big fan of your work. My question to you is, when we routinely do IMT and plaque assessment in the carotid, in a study where we had a cohort of patients who also had coronary calcium score measurement, what we found was that roughly about 30% of patients without carotid plaque actually had significant coronary calcification. So my question to you is, if a third of the patients without carotid plaque have coronary calcification, would that give us some misleading information, or are we missing subtle degrees of plaque by not measuring plaque area?
Yeah, so there is a study from Argentina that's been submitted to the Mayo Clinic proceedings showing pretty much the opposite, that carotid plaque area was more sensitive than coronary calcium in picking up disease.
No, I understand. I'm talking about individual discordance in individual subjects. Would you, if you had a negative carotid study, would you feel satisfied that there is no coronary disease?
Yeah, actually that's what Robert Brooks showed in ATDB in about 2006. He showed that absence of carotid plaque was a very strong predictor of the absence of coronary stenosis on CT angiogram.
No, coronary stenosis is something different than atherosclerosis. I mean, stenosis is a different measurement.
Yes.
Talking about coronary calcification, because it's a practical issue. I would love to start with a carotid study, and if it is abnormal, I'm done with screening. But if it is normal, I've been hesitant, gone ahead and gotten a coronary calcium scan, and there is a subgroup of patients without measurable plaque in the carotid that have significant coronary calcification, which we would have missed if we had simply relied on the carotid ultrasound. Now, you may be right that ones that we're missing could have been picked up by PD ultrasound or by measuring plaque area. I mean, that's a possibility. I would like to hear other people's opinion on this.
This is Jim.
Well, I think, I was going to comment that we do carotid IMT and plaque identification in all of our patients. We don't do calcium scores, but we measure all the other markers for vascular and cardiac structure and functional abnormalities. And it is amazing how unequally individual patients develop disease in one vascular bed versus another.
Right.
So certainly at younger ages, if you're dealing with 40 and 50-year-olds, you'll find a lot of discordance between the carotid presence of carotid plaque or carotid thickening and disease that we can detect in other vascular areas. And I'm sure the same thing would be true with calcium in that population, because in the 40s and 50s, calcium is relatively uncommon in the coronary. So much age-dependent and rate of progression in the different vascular beds.
I want to echo this. This is Jim Ehrlich. I've done about 50,000 coronary calcium scans and a huge number of carotid IMTs. And what's been shown generally is that women tend to get coronary atherosclerosis, carotid atherosclerosis earlier than coronary, and men are the opposite. So we commonly see men who are in the top quartile of a coronary calcium score that have absolutely no increase in carotid IMT thickness. And the opposite in women, we see women who are loaded with atherosclerosis in the carotids and have a 0 score. So I look at it as opportunity to look at 2 vascular beds.
Right.
And in the subsequent exams, I generally will do the opposite bed to look for peripheral disease in the carotid. So I I think they don't correlate very well.
The strategy that I've been using is you start with one test. If it is normal, do the other. If the first test is abnormal, stop there.
Well, we're actually doing a study right now where we're doing coronary IVUS in 3D ultrasound and looking how they correlate and how they relate to coronary risk factors. My feeling is that coronary calcium identifies calcified plaques, which are probably not high-risk plaques, whereas carotid plaque identifies soft plaques that are more high-risk.
Yeah, David, that feeling is not substantiated by MESA and some of these major trials that Matt showed, that coronary calcium is an indicator of risk, is probably an indicator of soft plaque and neighbor soft plaque and hard plaque. And the data on coronary calcium is just well beyond questioning. It's the data on carotid plaque. I don't really think we should contrast IMT and plaque. These two are same bed, the same technology, same focus, is that plaque and volume is a much better indicator. And but again, question is whether it's available. You're saying anybody can do IMT. I wonder if Jay Cohen can do in his. He's done this for decades now.
No,
Jay,
sorry,
can you do?
What I said was that anybody who can measure IMT can measure plaque area.
Yeah, we
identify
plaque and we characterize it, but we haven't quantitated plaque volume. I'm sure we could do that if we do it all in a rather quick fashion in our screening clinic. So it takes only about 10 minutes to do the carotid. So you can't do anything too lengthy in that period of time. But sure, it's not technically impossible to do it as a routine.
PK, if you don't mind, go around the room and then conclude the meeting.
Yeah, I think we've had a very nice session. Matt gave us an update on the current status on coronary calcium and the role of measuring progression. And Dr. Spence did an excellent job of highlighting the role of ultrasound assessment of coronary plaque being superior to IMT. And then we've had this general discussion on biomarkers. So it's been a good session. I think SHAPE is alive and well. And it's very gratifying to see that after many years of efforts on the part of many, we're finally reaching the audience and people seem to be listening.
Right.
That's my 2 cents worth.
Yeah.
PK, let me add one quick thing, which is that all of the discussions today and the slides that they coincide with have been recorded. So one of the things that we're able to do as a result of that is to send to you a full version of exactly what was discussed and so on today.
Mostly for other people who were not able to attend. SHAPE has always been mostly an online society rather than the small room that we got together. Every year, on average, we have about 10,000 viewers of SHAPE presentations. So all of these, whatever went to screen and whatever we talked, we didn't curse anybody. It will be available online for people to review.
And actually, based upon having sent this to the announcement of the meeting to a wider audience, I've gotten a number of requests for the slides as a result of today's work.
Thank you very much. That's very generous of all the speakers to share their work and slides. I think it's great.